I'd like to welcome you back to this third and final session of our annual scientific meeting. My name is Donald McIntyre. I'm Associate Medical Director for Mental Health at NHS 24, Consultant Psychiatrist in NHS Lothian, and Honorary Reader at the University of Edinburgh. I hope you've all had a chance to watch the poster presentations, which have been of a very high standard this year, and I hope you've all had a chance to vote on your favourite. Professor Gumley will be giving us the results towards the end of the session today. So this session is lasting around an hour and a half. For the first hour, we have two distinguished speakers who will be covering the topics of neuropsychiatry of COVID-19 and understanding suicide risk. Our first speaker is Professor Alan Carson, who has prepared a recorded talk this afternoon. As a result of an international diary malfunction, he will be unable to answer questions, unfortunately, but Professor O'Connor is present and is listening and will be able to answer questions after his talk. So I will go on to just briefly introduce Professor Alan Carson. He's worked as a consultant neuropsychiatrist in Edinburgh, split between the Astley Ainsley Hospital and the Western General Hospital for the last 20 years, but's recently moved to set up a new hyperacute rehab service for major trauma in southeast Scotland. He's honorary professor in neuropsychiatry at the Clinical Brain Science Unit at the University of Edinburgh, and he teaches, and his main research area is in is in conversion functional neurological disorders. He has been involved in many research projects over the years. He's published over 200 papers, and his favourite is getting a Jackie-style picture story into practical neurology. He's also written what he hopes will be a landmark handbook of neurology, published in 2016, and hosted an international conference on functional neurological disorders in Edinburgh, the largest ever interdisciplinary meeting on the topic. He was awarded the President's Medal of the Royal College of Psychiatrists in 2017. So we'll now look forward to hearing Professor Carson talking about neuropsychiatry of COVID-19. Please play the lecture. Thank you.
Good morning, everyone. My name is Alan Carson. I'm Professor of Psychiatry in Edinburgh. It's a great pleasure to have the opportunity to speak to you today about the neuropsychiatry of COVID-19. Before I start giving you my views, my conflicts of interest, for those who like to know, I'm a paid editor of the JNNP. I'm an unpaid president-elect of the Functional Neurological Disorders Society. I give independent testimony in court on a range of neuropsychiatric topics. So I want to begin by asking what we know about the direct early neuropsychiatric effects of COVID-19. At the beginning of the pandemic, along with a cast of thousands, I was involved in setting up the UK-wide surveillance study, very ably led by Ben Michael. And we just tried to get case reports of any neurological or neuropsychiatric complications of COVID. It's a tricky methodology, this, and one will almost certainly have under-reporting. Nonetheless, it gives a flavour of the type of problems one was likely to see. And we found a range of strokes. It's a well-recognised complication of COVID now, wasn't necessarily so back then. Significant amount of altered mental status, predominantly deliriums, and some peripheral neurological complications. Colleagues at the National Hospital in Queen's Square were particularly interested in encephalitis, and this was a concern early in the pandemic, that direct infection of the brain by the SARS-CoV-2 virus would cause an inflammatory illness. This is a national referral centre, and they reported on their experience. And they found a few cases of encephalitis. But I think perhaps the most interesting feature really was just how few cases there were. And I think it's now generally accepted, despite the widespread early concern, that direct infection and encephalitic complications of COVID-19 is a very rare complication indeed, although it does happen in some cases. But we need to be careful about these types of reporting studies. There was quite a lot of reporting of a neurological disorder, Guillain-Barré syndrome, which causes a progressive paralysis early in the pandemic. But when we had proper epidemiological studies, in fact, the evidence suggested that there were, if anything, slightly fewer cases of Guillain-Barré in the context of SARS-CoV-2. So you can see in the red line the increasing rates of infection in the first wave of the pandemic, and you can see some well-described epidemiology of Guillain-Barré cases. And if anything, it's slightly fewer. So we've always got to be careful of a sort of case report methodology. It's open to all sorts of biases, but it gives us a flavor of what might be out there. So what about data from controlled studies? Now, they're not necessarily going to be without their problems either, but at least it gives us some idea. And I think the best of the data still comes from the TriNetX Health Group in the US. This is a US insurance conglomerate, so you are going to have slight bias to those who can actually afford insurance, reporting on outcomes in COVID-19 patients and comparing them to influenza and similar respiratory tract infections. And it's data from about 250,000 cases, so it's pretty large. And what we see is that there is a spectrum of complication, getting worse the more severe the COVID-19 case is. So patients with hospitalization faring worse than those non-hospitalized, those in ITU higher rate still, and those with an encephalopathy. Encephalopathies, just for those unfamiliar with the jargon, mean essentially deliriums, slightly different from a direct encephalitis, which suggests direct infection. Delirium can be more distal and show some degree of inflammation affecting the brain. And what we see is a similar spread to what we expected. We can see stroke-like problems, but we can see some interesting hints at neurodegenerative illness, which was perhaps less expected by some authorities. We also see a fair amount of peripheral nerve disease and a significant increase in anxiety, depression, and psychotic illness. But let's drill down on this a little bit further. Now, here we're looking at the rates of dementia, and we're looking at the rates of mood anxiety or psychotic disorders. And we're comparing patients with COVID-19 to other respiratory tract infections, and we can see a significant increase in rate. However, if we redo that, and this time compare the patients with COVID-19, who are still staying in pink, but who were admitted with an encephalopathy, we see that they become distinct from the control group of COVID-19 patients without encephalopathy and other respiratory infections with and without encephalopathy. Seems to suggest that it's the presence of encephalopathy that's really causing the damage and the increased rate in dementias and indeed in mood anxiety and psychotic disorders. And that's perhaps no surprise. Encephalopathies, delirious illnesses have been known to be neurotoxic and to cause progression of subclinical cases of dementia anyway. So there's perhaps no great surprise that this would happen in the context of COVID-19. What's perhaps unusual about COVID-19 is that delirium is very common amongst younger adults. Given my age, which I'm happy to disclose as 53, I now count myself still as a younger adult in this context. Incredibly rare in general hospital practice to see somebody between 50 and 65 coming in with a delirium secondary to a respiratory tract infection, much more likely to occur in the over 70s, but seems to have a rate of anything up to 10% in COVID-19, or 10% of hospitalized patients, that is. So what about in general, just at a community level? Now, one of the problems, of course, during the pandemic was access to healthcare, and there's all sorts of distortion. So what we're ideally looking for is a study with population-based recording on repeated cross-sectional analyses pre and post-pandemic. And this Norwegian study, for my money, is one of the better in terms of methodology. There's a few in existence, and they all show more or less the same results, I would argue. And that is, at least if I can get the slide to go forward, that there hasn't been such a big increase in rates as is often commented on. So I apologize, I'm jumping backwards and forwards into have a sticky slide there. So this is looking at rates of common mental disorders in the community, pre-pandemic, first period of the pandemic when there was a lockdown in Norway, an interim period in Norway's second wave. And what one sees in general is a reduction in the rate of mental disorder. And we see the same with a reduction in the rate of suicidal ideation. And indeed, if we look at rates of completed suicide in a range of different countries, this data is from the US, we actually see a dip in the suicide rate during the first wave of the pandemic in the US, and that was replicated in the UK, Australia, France, and I believe Germany, if I'm remembering correctly. However, if we drill down a little further, this is from a similar methodology in the UK, finding similar results, broadly speaking, with the exception that they stratify by age. And I think this is a story across the epidemiology, that whilst people my age, perhaps not too much affected, in the young, there's been a substantive increase in rates of psychological distress, particularly those in the 16 to 24-year-old group. When you go younger and pre-pubertal, I would argue there's less evidence of any distress, but it seems to be in that key stage of development, sort of post-pubertal into young adulthood, where social networking is so important that problems occurred. And that's maybe not a surprise. For those who want to read about that more, Sarah Jane Blackmore wrote a lovely article in Lancet Child and Adolescent Health. Those who don't know Sarah Jane, she would be, in my view, the go-to person for all questions on adolescent mental health. She has done some fantastic work on the developmental aspects of psychopathology, and making this point that we know from both animal and human models how important social integration and peer interaction is during this period. And it's worth just highlighting for those who get very concerned about digital technologies, children on social media, that it's almost certainly had a highly protective effect in allowing people to stay in touch with their friends during the pandemic. So what about long COVID? So particularly interest of ours in research terms. COVID's an interesting condition in as much as the name starts from a social media campaign and disease activism. Now, there's some real positives in that it's a description of experience, but there's also some negatives in as much as the name long COVID has really sort of got off before the condition's ever been defined. We've almost started with the name of a disorder and are trying to work backwards to think what actually is it, even at the most basic level of an operationalized definition of the disease. And that causes huge problems in that a sort of political, and I mean politics with a small p view of what the condition may or may not be, has really become enforced before any basic research. But what do we really know about it? Sorry, again, a bit of a pause. So here's some basic prevalence figures. The top graphs come from the Zoe app, which I think through the pandemic has got more right than wrong. And I think the first thing to note is that they suggest that this is actually somewhat less common than many people would have us believe. I frequently hear reports on social media, anything between 30 to 50% of patients developing long COVID symptoms. And I think it's simply really not supported. The lower figure is just to remind us what the ordinary recovery from serious viral illness is. This is from an old study done by Ian Hickey in Australia, looking at Epstein-Barr, Q fever, Ross River virus, and just really reminding us that if you get hit with a serious viral infection, it does take some time to just recover and get back to full strength, the old idea of convalescence. And there's very little evidence to suggest that COVID is actually in some different spectrum. We might be partly looking at, and we have to be mindful of this, is just the ordinary convalescence from viral infection. More recently, the ONS have published more detailed data. It's probably one of the best data sets in the literature, giving us some idea of rates in the UK from April 20 to August 21. And at about 4 to 8 weeks post-infection, about 9% of people who've had COVID-19 are still reporting symptomatology. It's important to recognise, however, that many of the symptoms complained of under the sort of flag of long COVID are actually pretty prevalent in the community in general. So about 4% of just basic healthy controls are complaining of similar symptoms. And when we get 12 to 16 weeks, generally speaking, 12 weeks is often now used as the cutoff for long COVID, we see the rate above community rates is not actually as high as we're led to believe, 5% of participants versus 3.5% of control subjects. And in some age groups, particularly the young, it's important to remember much of what's flying under the flag of long COVID may just be the ordinary ailments of childhood, and in fact, slightly higher rates in control participants. It's not to suggest there isn't a condition or set of conditions, as we'll come on to, that are caused by COVID infection, but it's just to remember when we're looking at things, the all-important control group and just how common many of the symptoms complained of are. So what are the typical types of symptoms? This is quite a nice study out of an early Parisian cohort. Now, it takes a little bit of time, but we're looking at 177 patients, all of whom had hospitalization at 4 months. And each individual circle with a number in it is the number of patients with a particular complaint. But what I really want you to look at is the colors round the outside that join groups of circles together. And what we see is that cognitive impairment accounts for a significant proportion of patients, with the red sort of pink ring round the outside, and with the blue ring round the outside, psychiatric symptoms again account for a big proportion of patients. And dysfunctional breathing is quite common, and it segregates relatively well from patients with fibrotic lung lesions, which is also a significant problem. There are many people who end up with damaged respiratory function. This is from an early systematic review, which gives us some idea of COVID symptomatology. It's worth taking a look at this and realizing that very few of the conditions rested necessarily have a discrete pathology. So we have 5% of patients with pulmonary fibrosis, 10% with reduced pulmonary capacity, actually far lower figure than the 24% who are complaining of breathlessness. A lot was touted earlier. You probably saw media reports about cardiac disease, really from doing early uncontrolled MRI studies that actually were highly misleading. In fact, myocarditis as a complication of COVID in terms of long COVID is as rare as hen's teeth, if it occurs at all. And the general view in cardiology is that you're getting people with coincidental occurrence. The majority of symptoms, however, don't necessarily lead to an obvious pathophysiological explanation. And that's quite an important take-home message. Now we can look at this further again from French data. And this is looking at the cognitive complaint, comparing it to psychometric testing and also psychological distress. And what we're seeing is what predicts cognitive complaint. And if I can take you to the bottom two rows of the table first, you'll see SVFT, which is essentially a form of verbal fluency test, and DSST, which is digit symbol substitution test. These are two core neuropsychiatric or psychometric tests that would be used in psychometric assessment. Would particularly expect to be affected by any condition causing acquired brain injury. And what's fascinating is they're completely not predictive of poor cognitive function in the aftermath of COVID. Paradoxically, ICU admission across the population actually has a negative effect. So there's something quite strange there. And what we see is that the hospital anxiety and depression score is the more predictive measure. In other words, it seems to be distress that is predicting poor cognitive function after COVID infection, rather than direct damage to brain function. So that gets us thinking about, well, what might that look like? We're going to step sideways and look at functional cognitive disorders. And this is a statement from some leading authorities on functional disorders and on dementia, trying to define what we mean by a functional cognitive disorder. And what we're trying to get at is conditions in which we have clinical evidence of internal inconsistency. In other words, there's evidence that when a memory or indeed any other function is being conducted automatically, it works, but it does not seem to be able to work under voluntary command. And there's a range of reasons why that might happen, but that's the basis of the definition. So the sort of differences we might see in somebody attending a memory clinic with degenerative brain disease versus functional cognitive disorder. So the person with functional cognitive disorder will tend to attend alone. They'll be more concerned than their relative, but they'll give long, detailed accounts and elaboration. They'll give examples of memory failure. In other words, they'll actually demonstrate episodic memory as they go. And they'll be able to answer compound questions showing working memory is intact. It's a very different presentation. Now, at least if I can get my slides to go forward, I'll hopefully show you what that might look like with some patient recordings. I do apologize, this is embarrassing. This is a patient with dementia. Tell me about the problems you've been having. Well, I don't know, bad memory, always check with my husband. Daughter says, I don't remember our shifts. Other than that, my memory is fine. Whereas the patient with functional cognitive disorder is its forgetfulness. For example, I forgot the name of the doctor I saw in clinic, Dr. X, had to check his name. It's frustrating. I'll watch a film and think, who is that actor? For example, I was watching a film called Pimpernel Smith, couldn't remember the actor in it. Leslie Howard, of course. I remember things 40 or 50 years ago, even 4 or 5 years ago. Sometimes I struggle with finding words. The other day I went out to meet a pal, took my jacket off, thought I'd lost my wallet, but I just put it on the side. The detailed remembering of these episodes of forgetting actually demonstrates that episodic memory was intact during that period. And this is what we mean by internal inconsistency. Psychometric tests, however, fail to predict this. So if we're looking at the use of the Montreal Cognitive Assessment Battery, the MOCA, it's a common cognitive tool, it's absolutely not predictive of those with dementia versus those with a functional cognitive disorder. Whereas the simple duration of response, a more qualitative measure of, or quantitative measure of that qualitative interaction, if you like, actually has really quite good prognostic properties. So how might we be perceiving these? Well, we'd be perceiving this really as a disorder of attentional dysregulation rather than of true memory impairment. And normal memory lapses, we could say cognitively, are being viewed as task failures, causing prediction in the neurological sense of cognitive failure, and having a change from automatic to effortful cognitive activity and the problems that causes. Now, we can make our model much more complex, but the interests of your mental health, I won't go into this in too much detail at this point in time. I just want to give you the general idea. So what we would be suggesting is that there isn't really such a thing as long COVID, and that there is a host of reasons for symptomatic impairment after COVID-19 infection. And these will include, very rarely, post-encephalitic impairment, more commonly, but still relatively rare, post-stroke impairment. There is pretty strong evidence now of a somewhat increased rate of dementia in the elderly, probably triggered by delirium. But also delirium triggers psychological responses, post-traumatic stress disorder, and that in its own right can cause attentional dysregulation. Persistent respiratory symptoms can cause problems, chronic lung disease, but a large chunk of this pathology is functional neurological disorder. And I think what's important is we can separate out and establish that. And this is what our own research is as part of the chief scientist's call. Just to flag, we're running a clinic that does both research and clinical assessment. You get detailed consultant-led clinical assessments backed up by state-of-the-art brain imaging, plasma biomarkers of neural degeneration, CSF biomarkers of the same, consensus diagnosis and treatment. Sorry, again, slide problems. Don't know what's wrong with my computer today. I do apologize. This is the rough patient journey for those who like to see these things. Clinic is open to anyone in Scotland with cognitive problems after COVID-19 infection. The only criteria is they must have documented evidence, as in serological testing and confirmation COVID test, but we're quite happy to see anyone referred, and they can be referred to me, Alan Carson, Department of Clinical Neurosciences, Royal Infirmary, Edinburgh. So to conclude, I think it's important to remember that not everything is COVID. People are still people, and the same risks of mental disorder still apply. The rates of all neuropsychiatric disorder go up following COVID-19 with encephalopathy, but absent encephalopathy, much less clear picture. I'm not sure that proper epidemiological evidence supports the idea that the pandemic has had a major effect on mental health. Lots of people are fed up and bored of it, but that's not the same thing as mental disorder, except in the 16 to 25-year-old group who have been hit hard by this condition. I haven't shown you the data in the interest of time, but income disparity has an impact on mental health. COVID has magnified existing problems, and this may yet be a mental health crisis to come. About 20 to 25% patients report persistent cognitive problems 3 months after COVID-19. We don't definitely know why, but I've given you some hints at what the data suggests. And I think it's particularly important we do detailed phenotyping assessment to work out what the different causes are. And as I highlighted, we're happy to see any patients anyone has if they're willing to travel to Edinburgh for study. And I think what I'd say on that is that I think clinical phenotyping is still the bedrock on which research occurs. I think what COVID's shown us is you can only interpret biomarkers in the context of detailed clinical understanding. It's also important to remember biomarkers only really tell us whether disease is present or absent. They don't necessarily inform an underlying cause of the symptoms. And I think we need subtyping to inform treatments. I'll thank you for your attention. I'm sorry for some reason I was having slide problems, and I hope you're having an enjoyable conference.